Welcome to the webinar, Building an RT-Driven Vascular Access Team. This event has been approved by the AARC for 2 CRCEs. I hope you enjoy the presentation and learn something new today. This webinar's content was created by JJ Valdez. JJ is a respiratory therapist who was one of the key players that built an RT-driven vascular access team at Midland Memorial Hospital. The cardiopulmonary manager at Midland Memorial Hospital in Texas is Holly Baker. Holly and JJ's team has really become the gold standard for this type of practice in Texas. I graduated from the respiratory program in 2007, and vascular access was not discussed at all in our curriculum. When I started working as an RT at an acute care hospital, I did work with a respiratory therapist that placed PICC lines. I honestly assumed that he had some sort of other certification beyond his RRT credential. I had no idea that vascular access is within respiratory therapist's scope of practice. The AARC released a position statement in July of 2015 supporting the practice of RTs placing and managing vascular access devices. Banner Health in Arizona identified a gap in their vascular access services, specifically for central venous catheter placement. Traditionally, central lines had been placed exclusively by physicians. Banner Health trialed a pilot program and trained RTs to place vascular access devices. The trial was a success. Central line-associated bloodstream infections, also known as CRCEs, went down, and patient satisfaction scores went up. Banner shared their success story. UT Southwestern in Dallas and Midland Memorial Hospital in Midland, Texas, followed suit. UT Southwestern's respiratory manager, Stacy Cutts, went to the Texas Medical Board in 2017 and got it on record in meeting minutes that the TMB recognizes vascular access as being within the scope of practice of respiratory therapists. In preparation for this webinar, I reached out to as many hospitals as I could find that currently has RTs placing CVCs and/or PICC lines. These 15 hospitals from 6 different states across the nation utilize respiratory therapists as vascular access specialists. The national benchmark for central line associated bloodstream infections is 1. CRCE rates are reported to the public by the Centers for Disease Control and Prevention, the CDC, and can be found on Medicare.gov's Hospital Compare website. These rates are not exclusive to RTs. They include all central lines placed by all disciplines, including RNs, RTs, physicians, and mid-level providers. When you look at these numbers, oftentimes the RT numbers are even better than the national reported rates. For example, UT Southwestern's RT vascular access team has a CLABSI rate of 0. Midland Memorial's RTs also have a CLABSI rate to date of 0. I'm writing an article right now that I hope to get published in the Respiratory Care Journal. It tells the stories of these 15 hospitals and their journey to implementing and sustaining successful RT vascular access teams. I'm glad I've had the opportunity to connect with the leaders of these teams and then connect them with each other to encourage collaboration. Respiratory therapists, regardless of what role we play, have historically worked in silos. We don't talk to each other enough. We should share best practices and celebrate each other's wins. Every team's path to implementing an RT-driven vascular access team will look different. It depends a lot on the hospital's senior leadership. UT Southwestern and Midland Memorial were both fortunate enough to have support right from the beginning. Floyd Medical Center in Rome, Georgia, had a slightly different experience. While their senior leadership was on board, they got pushback from nurses and mid-level providers who insisted RTs were not qualified to perform vascular access procedures. Floyd Medical Center's cardiopulmonary director, Jeff Thompson, comments on the opposition his team endured from nursing. Nursing was opposed to this, mainly in the critical care areas and the emergency department. A couple of nurse practitioners did not like it either. Over time, we just kept our heads down and kept going. We had to take it on the chin, so to speak, for a while, but that has now passed, and all have gotten on board. We brought the CLABSI numbers down to where they should be for a facility of our size. The service used to be contracted out, and vendors would come place lines with no oversight at all. These contracted services cost our hospital about $300,000 a year. Ironically enough, our plan started out to place only midlines, PICCs, and arterial lines. But after nursing started recognizing our expertise, they asked us to take on the extra responsibility of inserting ultrasound-guided peripheral IVs. Now we start approximately 150 PIVs every month. If you are interested in starting a program at your hospital, you can definitely benefit by learning from teams who have proven to be successful. I personally first learned about RTs working in vascular access at a conference put on by the Texas Society for Respiratory Care in 2017. After attending that workshop, I went back to my home hospital and I was ready to hit the ground running. I worked at a hospital that didn't have RTs placing any type of vascular access. Not arterial lines, not IVs, PICCs, midlines, and definitely not CVCs. The only needle puncture procedure my hospital let respiratory therapists perform were arterial sticks for blood gases. I did my research and I created a big, beautiful proposal to deliver to my respiratory director. Unfortunately, it turns out the only running I ended up doing was straight into the brick wall that was my respiratory director. See, she and I did not have the best of relationships. If you've listened to the workplace bullying webinar, think of the relationship between Mary and Ethel. Yeah, it was that bad. When I come across an idea that I know will improve patient satisfaction, build staff morale, and save the hospital money, it's not in my DNA to just let it go. With the idea being shut down by my director, I knew I needed to go back to the drawing board, think outside the box, and really get creative. I had started Lean Six Sigma training, and I realized that I needed to create some sort of performance improvement project related to my original idea. On a daily basis, I performed about half a dozen blood gases each shift. So I thought back to the technology I was introduced to at the TSRC workshop. Point of care ultrasound, also referred to as POCUS. And I decided to start using POCUS to guide my blood gas sticks. Several nurses in my facility placed ultrasound-guided IVs. So I asked nursing leadership what checkoff I needed to start using it for ABGs. Nursing leadership actually just gave me the green light, saying that I already had a competency for the invasive part of the procedure, and POCUS is just a tool to improve the process. Now, I'm not telling you that this will be the case at your hospital. I definitely encourage you to find out your healthcare system's expectations before you start using the skill on patients. My next step was to find a machine to use. I was surprised to find several POCA systems that were just sitting around collecting dust. For me, PACU was a gold mine. Our chief of staff happened to be an anesthesiologist. I reached out to him and asked if I could use one of the PACU machines for my project. He immediately agreed, saying that his team really doesn't even use them because they hardly ever miss. Perfect. I performed 50 ultrasound-guided arterial punctures, and then I trained other RTs that skill. I started collecting data comparing the traditional blind stick palpation method with the ultrasound-guided method using point-of-care ultrasound technology. What I found was that the ultrasound-guided technique improved first attempt success rates and actually shortened the procedure time. Those are the results that I expected to get, but now I had some black and white data to support my hypothesis. In addition to the positive results of the project, the other big accomplishment that I made was the buzz I created around the hospital. Physicians and nursing staff were so intrigued by seeing these respiratory therapists running around the place with these ultrasound machines. Many times, providers, nurses, and PCTs would ask to observe the procedure. My director apparently felt the pressure. She actually tried to get the project shut down. She made a complaint to our compliance department, claiming that I was conducting research without IRB net approval, which of course was not true. I went through the IRB net review process, and they deemed it to be a quality improvement project, not research. I provided a letter from IRB net to the compliance officer and was cleared to go about my business. Tension continued to grow between my boss and I, and ultimately I resigned from that position. Fortunately, I had secured a PRN position with the same healthcare system as a clinical educator. There are a dozen acute care hospitals in this healthcare system, and I was the sole respiratory educator for all of them. I never let go of my original goal to implement an RT-driven vascular access team at this organization. It was a hard-fought battle. It challenged me in ways I had not ever faced in my professional career. But I am happy to report that after presenting this poster at half a dozen respiratory therapy conference and keeping the buzz going, there is now an official job code at this healthcare system for respiratory therapy vascular access specialists. The journey is always possible, but some paths will be rockier than others. My project looked at just arterial punctures. There was a similar study done in China that captured data from both arterial punctures as well as arterial line placements. This study also proved that using ultrasound improves first attempt success rates and decreases the amount of time required to obtain arterial blood. Additionally, the supporting study captured data on the number of hematomas caused by the procedure. Hematoma rate decreased from 20% for the blind stick method to just 2.5% for the ultrasound-guided group. Once you get the approval to implement an RT-driven vascular access team, where do you start? Interestingly enough, Banner Health and Midland Memorial started with central venous catheters. Of course, the jugular and subclavian veins are much bigger targets to hit than the peripheral veins, But jumping into CVCs first was also very risky. The reason that Banner and Midland started with CVCs was because this is where the greatest need was identified at their facilities. As the RT teams demonstrated their excellent work at placing lines, they were asked to expand their umbrella to include PICs, midlines, and PIVs. JJ Valdez says that if he had to do it all over again, his team would do the opposite. Start with PIVs, then go to midlines and PICs, saving CVCs for last. UT Southwestern took the advice and started with PIVs. Stacy's team placed more than 600 ultrasound-guided IVs in a 6-month period. Her team now inserts IVs, midlines, and PICs. Stacy says that the key to her program's success is training narrow and deep. She recommends starting with 2 practitioners. Train them extensively so that they are not only competent with the skill, but train them until they become the experts. Midland Memorial Hospital appreciates the importance of collecting data. They have been documenting their journey from the very beginning. Midland now has 15 RT vascular access specialists. RTs 1 and 2 on this slide reflect JJ and Holly's placement numbers. The blue represents the number of successful attempts, and the black represents the unsuccessful attempts. Having been at the bedside in ICUs and EDs for over a decade and observing physician-placed lines, these success rates are beyond impressive. The RTs at Midland Memorial Hospital have attempted 751 line placements thus far. They have had an 89% success rate with 0 CLABSIs. The providers have recognized the team's excellence and actually requested that the team start placing tunnel dialysis catheters. They probably will add this to their wheelhouse in the future, but they want to take it slow and ensure that they can safely take on this additional procedure. Midland Memorial's respiratory leadership is a prime example of how you can be cautiously innovative and raise the bar for patient care. When I was researching vascular access services, I was shocked by how many hospitals are still contracting the service out. Jeff Thompson said that Floyd Medical Center's contracted vascular access services was costing the organization $300,000 a year. RTs are staffed 24/7 in acute care hospitals. There definitely exists an opportunity for us to fill this gap. It is vital to the success of your program to educate, and educate some more. As RTs, we all went over anatomy in school, but how many of us received in-depth education on vascular anatomy? I sure didn't. That's where you should start. I'm a huge advocate for point-of-care ultrasound technology. In our acute care hospitals, these machines are actually all over the place. When I was doing my project comparing blind sticks to ultrasound-guided sticks, and I would meet resistance, often from veteran RTs, about learning to use ultrasound to guide needle puncture procedures, I would simply ask them, when you get an order to draw a blood gas, how many ABG kits do you take with you? I'm not sure that any RT who ever passed the therapist multiple choice exam would say they always take 2 kits. After I performed 10 arterial punctures using POCUS to guide me, I stopped taking a second kit with me. I didn't need it. It was a waste of time for me to take the extra steps to return the second unused kit. I encourage all practitioners to use point-of-care ultrasound for both needle puncture procedures as well as for bedside patient assessment. Arguably, the most important rule to follow is to adopt a standardized process and stay true to it. every procedure should be done the exact same way, regardless of which RT is performing it. Knobology is a term that describes the manipulation of ultrasound knobs and system controls in order to obtain the best image possible. When using POCUS, you can view the image of the vessel transversely, where the vein or artery will appear as a round hole on the screen. Or you can take the linear approach, and the vessel will run horizontally across the POCUS screen. The transverse view is generally felt to be easier. When it comes to placing lines, though, it is definitely worth it to learn the more advanced linear approach. Depending on the POCUS system you're using, you may be able to take a picture and upload it into the patient's EMR. You can show proof that you placed the appropriate size catheter in the vessel you chose. Learning proper sterile technique is key to avoiding line-related infections. It is now recommended to have a second person present during the sterile procedure to ensure that the sterile technique is done correctly. There are a couple different ways to confirm line placement for PICCs and CVCs. You can use 3CG technology, which eliminates the need for a confirmatory chest X-ray. You can also use POCUS for bedside patient assessment. You can examine for DVTs, and you can use it to assess your patient's lungs. Point-of-care ultrasound is the fastest way to diagnose a pneumothorax, and your patient does not have to get exposed to any radiation. I encourage vascular access teams to follow their own lines. Contract services come in and place the line and leave. The maintenance is put on the bedside nurse. Having RTs in-house that place lines and follow those lines can improve hospital CLABSI rates. I hope you all take Stacy Cutt's advice and train narrow and deep. Midland Memorial requires 2 successful ultrasound-guided arterial punctures to prove competency, 3 ART line placements, 3 midlines, 5 PICC lines, and 25 CVCs. Whatever your facility decides on, you also need to think about how to maintain those competencies. To sum things up, respiratory therapists have an opportunity to fill a huge gap in healthcare right now. Especially with the new sepsis guidelines, we can establish vascular access sooner and improve patient outcomes. Midland Memorial RTs have 0 CLABSIs to date. The 2 complications they did have happened when a physician was training the RT and the procedure went off course from the standard process. Consistency is essential to your program's success. Treat people the way they are, and that's what they will remain. Treat people the way they can become, and they will become that way. Jimmy Johnson. Do you work at a facility where respiratory therapists do nothing that nurses couldn't take over? It is so very important for us to maximize our scope of practice. Vascular access is one way that we can do that. To receive your CRCE certificate, please email your answers to the post quiz to heroesofhealthcare@gmail.com. Your certificate will be sent to you electronically. Name one of the founding fathers of RT-driven vascular access teams. What technology should your team use to help guide needle puncture procedures? Identify one hospital that currently uses RTs as vascular access specialists. If you have questions about this presentation, feel free to reach out to JJ or Holly. Additionally, you can always email heroesofhealthcare@gmail.com. Thank you so much for participating in the webinar today. I hope you enjoyed the content and learned something new.